ASAP clinic through UNMH. And this is a 55-minute series, and it is free. It is focused on providing the basic fundamentals of a topic presented by an expert in that field, and it's clinical education to assess folks working with people with mental health diagnoses. And again, these are the basics, so hopefully you'll be inspired to go out and learn more outside of here. You can check out the next slide here. So please have your mic on mute for our presentation and write any questions in the chat. We'll answer them at the end or as needed as they come up. And please drop in the chat where you're joining us from. So if you want to join, like drop in the clinic, the organization, maybe the city and state you're joining us from. And after today's presentation, you're going to get an email from Erin Watts. She's our other coordinator, and it's going to have the slides from today. So you'll get your own copy of the presentation, and you're going to get a link to a survey. Once you complete that survey by adding your name and your email, you'll be emailed the CEU certificate. And our didactic series is honored by the New Mexico Credentialing Board. So for behavioral health professionals, for CEUs of all behavioral health professions. So that's therapists, social workers, certified peer support workers, all of them. And for nursing contact hours, we can check out the next slide here. Oh, this is everybody that's involved. For nursing contact hours, you're going to have a QR code to scan at the end. And I'm going to drop a link in the chat to click as well. And you'll follow that to take a survey that's going to give you your credit for being here today. So please, everyone who's attending, make sure that you follow the registration link in the invite that you got. So once you're registered, we'll know you're here and we can send you all this stuff. We can check out the next slide here. That's everybody that makes this possible. And we can check out the next one. Okay, and today we have the pleasure of having Dr. Fernandez. She's the Director of Psych Providers and Behavioral Health Clinical Services here at UNMH, and she is presenting on risk assessment and crisis planning. I'm going to hand it off to you, Dr. Fernandez.
Yeah, thank you so much. And I don't have anything to disclose when it comes to getting paid for the presentation or any content that is in the presentation. At the end, you'll see a reference list, and then you will also see for videos or anything that I share, the links within the slides. So hopefully you can find them. And again, there's no monetary compensation. There's no money being paid. And as Kyle mentioned today, we're going to talk about risk assessment and safety. I put crisis in parentheses, and we'll talk a little bit about that. I think last week I was trying the Poll Anywhere. I didn't realize that it had a limitation as to how many people could actually enter the response. So let's go ahead and do good old chat, put it in the chat. So when you think, and so let's get started. So when you think of risk assessment, what is the one word that comes up for you when it comes to behavioral health? Suicide, very good. What else? Safety, preventing, okay, triaging, suicide and assessment, self-harm, very good. Not just suicide, behaviors. That's right. What suicide as well. Self-harm, risk to self and others. Very good. Not just from patient towards patient or client towards a client. Care plan, care coordination, harm to self and others. Very good. So yes, everybody's in the right track. I'm also thank you for sharing today. Even what kind of role do you serve wherever you are, even if it being a student, being if you're working, that gives us a bit of an idea. Like Kyle said, today we're going to be talking about risk assessment and if you think of last week when I also got to present, I really want us to think as to why it is that we do the things that we do, right? And so some things may feel a little basic, hopefully not too much. So if you're somebody who is very experienced, maybe you can use this in supervision of those who are starting. And then for those of you who are starting, hopefully some of this, some of what is presented today makes it a little bit clearer. Please, please, please feel free to write in the chat. any questions that you might have along the way. I know Kyle will be helping me with that. I have 2 extra screens, so if I'm looking to one side or the other, I'm actually looking at the screens. So yes, very good. I'm very glad to see that it's about, we're talking about the risk to the patient, the risk to the patient, to himself, herself, themselves, or others. And we're going to talk a little bit more about us being in the room, right? Whether you are a peer, whether you are a nurse, or a therapist. Very good. Okay, thank you. Okay, so the objectives for today, we'll talk a little bit about SIHI theories, but we really are going to talk a little bit more about protective factors and risk factors for suicide ideation and homicide ideation. One of the things that you'll notice out there in terms of information, it's a little bit trickier when it comes to homicide ideation, because the steps are similar to suicide ideation, but we don't talk about it too much. Still very important to address. There are certain risk factors that would be very important to consider, right, for risk. So what I'm going to take us through today, it's kind of like steps, right? Like what do we do? What is it that we are supposed to be doing on every session versus that one-time session when we finally hit a crisis and we have to kick into risk assessment mode. I think when we're starting out, I mean, I can talk about, share from my perspective. I remember often feeling very scared. I was in situations similar to ASAP where you can see kind of like it wasn't a chat, it was in person, but you could see when clients were coming in, and every so often you hear somebody's coming in a crisis. And I remember starting out and feeling so worried and apprehensive as to what would I do. And if it felt like there were form after form that had to be filled out. And then my biggest fear was always, what if I miss something? What if I send someone home? What if I didn't document enough? What am I liable for? What did I fail as a therapist or even as a human being, right? Like, if I happen to witness that, or not witness and see, but like be part of somebody losing a life, right? So very, very apprehensive. I think many of us might feel that way. And what's really interesting over the years is realizing that that's more of a reflection of lacking training and resources. So lacking training within our school, and when we go to organizations that might not let us know, how do we treat risk? How do we address suicide ideation? How do we address homicide ideation? So it feels this really obscure, like only a few people in the team know, and it should not be the case, right? So we should definitely talk a lot about it more. And then the other thing is sometimes being informed, being taught, but not enough, right? So filling out forms, how do I document? What is it what is specific language that I must use? So that's the idea of today, kind of taking you from a perspective of different areas, 6 different areas, as to hopefully areas that can help you to always be collecting information. I think I do, and I forgot to share this at the beginning, I do supervision in English and Spanish for psychology, counseling, and social work trainees. And it's really interesting when we have those conversations about what do we do in those situations. What do we do at different levels of education, right? So if you're a trainee that is in internship or practicum, there's certain steps to take, right? Like always alerting your supervisors, versus like if you're non-independently licensed versus if you are independently licensed, right? So anyway, so let's go ahead and start with the first one. So one of the things that is very essential, which we talked about, if you think of last session, we talked about case conceptualization and formulation. We're constantly collecting the data from the moment that we start seeing our patients. When it gets really tricky is if you're inpatient and you're seeing that patient very briefly, and you get to do a very thorough data collection from the patient, But the beauty is you can always collect that information from the chart, sometimes collateral information. So it's very important. And if you have questions, if you were not here last time, I know Erin is uploading the videos, so please look into it. We talked about like concepts and areas that should be included in our case conceptualization and formulation. And so it's very important that at the beginning, in that first session, when we're collecting data, we're also collecting data about risk, right? We want to know what is the patient history? Has the patient ever been, have they ever had ideation, thoughts of not wanting to be alive, thoughts of killing themselves? Have they ever rehearsed it, right? So, etc. It's interesting to sometimes discover patients that share what, yes, you can rewatch. Yep, you can rewatch it. The only thing is you won't receive CEUs, but you're welcome to rewatch them. Lost my train of thought. The family history. It's interesting to sometimes find out that a patient for the first time shares with us, maybe a time where they had some thoughts, but they completely dismissed it. And the person that was collecting the data asked in a way that completely dismissed it and it didn't seem relevant, right? So the patient did not want to disclose it, or the patient felt like the provider or the individual collecting the data was a little judgmental and they were not feeling safe enough, right? To be able to share. We do want to know family history. We definitely want to know if an individual has had relatives, parents, siblings that have died by suicide, because there's definitely a very strong correlation, right? So our patient is already at a higher risk. So it's very, very important for us to know. I was thinking notice that I said die by suicide versus committed suicide. Does anybody know why we shouldn't use committed suicide? You can put it in the chat, or if you want to unmute. Okay, stigma, very good. Why else? Does anybody know where the origin comes from? Committed can imply, yes, that it is a crime. Believe it or not, it was punishable by the law if you committed suicide, right? Whatever that means. So definitely, yes. So when we hear committed suicide, there's definitely more judgment. Oh, I like that, Lindsay. Less accusatory. So committing a crime sounds more accusatory than dying by suicide. Yes. So, but the origins were that it used to be a crime. It used to be actually a legal crime. It is still unlawful in some countries to die by suicide. So, so something to consider when you're treating somebody from a different culture, ethnic, racial culture. So yes, we should really change that language and talk about someone dying by suicide or attempting suicide. Attempting can be a little tricky, but attempting, it is still accepted, but definitely committing suicide, not accepted, right? It's something that is not related to legal matters. On another side, you'll notice in this set of slides, there isn't as much statistics. There's plenty of data out there to find out, and I'll mention some data. The purpose was to talk a little bit more about that risk assessment. But one of the biggest issues with suicide rates is that they're not as accurate. They're not maybe the full picture. Any thoughts as to why? Does anybody know why is it so difficult to collect data on suicide attempts, suicide gestures? You hear people saying suicide gestures, meaning people who were trying. Stigma, right? Both in asking and sharing, right? Shame, that's right. So in not reported, right? So there's a lot of shame. Not unheard of. The families might say, no, that was not suicide. That was an accident, right? Uncounted, very, very right, Terry. That's That's the main thing, uncounted populations, right? So we might have individuals who died by suicide who were not counted, and we might have individuals who died accidentally who were counted as a suicide. So it's not even clear. But yes, I like that many of you are putting not reported, and Anna, you're very right. Sometimes even our families are in much denial and do not want to share, right? Nothing like somebody attempts, they end up in the hospital, they go visit them, they talk about everything else, they come out, they talk about everything else, and nobody talks about it, right? Nobody addresses it like it never happened. Yes, religious reasons. Thank you, Victoria. That's also in culture, definitely culture, right? Not just culture about religion. So we definitely always want to keep that data from the moment that we see that patient. So it's our baseline, right? Because nothing like seeing the patient and all of a sudden they hit a crisis and we have no clue if this is how they generally manage their crises. So say, for example, somebody who has chronic suicide ideation, chronic thoughts of wanting to die, versus somebody who this is not their typical self, right? So, and the reason being is the approaches are just a slight bit different. You still are assessing. We're never going to guess, is my patient just seeking for attention? Never, right? So we're always trying to keep our patients alive, right? I think we're going to talk a little bit about collaboration, but we can talk about like when we have to send our patients and they're not very willing, right? Like when there are ruptures, so we can talk about collaboration, but we are always going to err on the side of keeping them alive. A patient that is not alive cannot get better, right? So, okay, number two. So number one, we use that baseline information. So you always want to start your sessions, your intakes with gathering that information, right? Maybe you didn't gather that information, maybe someone else did. Make sure that you're able to read the chart, right? I know sometimes we're very pressed by time, but nothing like doing a good chart review. Number two, screening tools, right? So you want to know how they're doing in terms of symptoms. Even, again, going back to the baseline, from the moment that they come to see you. Notice that I put different ones here. PHQ-9 is very important because we know that suicide and homicide are connected to depression, anxiety, trauma, and substance use, substance and alcohol use. With homicide ideation, sometimes it's a little bit more linked with psychosis, where you might not see that with suicide ideation. But again, we want to prevent any accidental deaths, right? So when I was in El Paso, I was working with the National Alliance. We were working on their programming, National Alliance on Mental Illness, NAMI El Paso. And I remember attending a presentation one time in terms of talking about how do people assess when police comes into a situation that is a crisis situation. They will call it a crisis situation. They might talk about the details, but not differentiate too much, because they in terms of suicide and homicide ideation, because when they go to the site, they assume that if somebody is willing to harm themselves, they're willing to harm others because they're just not in a good place. And so that's interesting to hear, because for us, that might be something to understand, right? Like our patient might not be in the best place. They are wanting for something to stop. And this at that moment seems to be a solution. I think I'll mention his name. I saw a presenter who talks about losing his sister to suicide. And he talks about how people say it is a permanent solution to a temporary problem. And I love that he actually corrected, I don't know if somebody mentioned it or yeah, somebody mentioned it in the chat. And I love that he said, no, it's not even a solution. Suicide is not a solution. So we have to talk about it. We have to address it. Okay, collecting data tools. PHQ-9, 9 symptoms, right? So it's checking 9 symptoms and it's checking severity. Notice that it says screening tools. Question for you. Can we use screening tools to diagnose someone? And you don't mind sharing why or why not? If not, just say yes or no. Can we use screening tools to diagnose someone like the PHQ-9? Up to a point, I like that. Yes, but maybe, right? Or depends. Okay. Yes and no. I see that. Okay. Yeah. Can information, there you go. The information maybe might be sending us to the right direction in combination of clinical judgment, right? So here's the thing. If it's a screening tool, it's only going to tell you yes, probability of depression, no probability of depression. That's all it tells you. It doesn't even tell you if that person actually has depression. If you look at the PHQ-9, the questions that it has, if you answer 0 or no to the first symptom, which is has your mood has been low, and you answer really high to all the other ones, it's going to give you a score of 20 something. So if you don't pay attention that question 1 was non-significant, you will assume that someone has very severe depression, but they don't even have a mood change. Their mood is good, but they're having no concentration or having issues with concentration, issues with appetite, issues with sleep. What are some other things that would affect your sleep, your concentration, your appetite, other than depression? What do you think? What are some other things that are not depression? That's right, PTSD, anxiety, correct. There's so many other things that might share similar symptoms. So be careful if it says screening tool is just meant for you to know how bad something is, right? So how bad is someone feeling in terms of their mood? How bad, yes, that's right, Anna. Some conditions mimic, right? Oh, I like that, Heather. Yes, they are self-rating tools, right? So we have to be cautious. So we want to know if somebody hits a 13 and higher, said yes to the depression, said yes to that, even if they didn't say no, you want to check what's going on. At 13 and higher, we're getting to moderate, right? We have somebody who's feeling their depression started to feel moderate and a little bit higher. Okay, yeah, high A's counts, very good. Adverse childhood events, right? So not just, and I like that, Terry, you're referring to the third one. The PC stands for primary care PTSD. So it's checking to see whether or not there's a presence of trauma, and maybe is saying, yes, possibility of PTSD, please check further. That's really what those tools tell us, right? And so, so that's the PC-PTSD. 5 questions. It just tries to see where did you experience trauma and related to that specific traumatic event. That's very important. To that specific traumatic event, are you feeling this, and so 5 elements. The DASS asks, are you using substances? How much? Is it affecting your interpersonal relationships? Are you now in trouble with the law, etc.? Right? Has somebody told you that you needed to get help, right? Yeah, so those are other, okay, Alexander is actually getting a little ahead of me, yes, right? Medical anemia, okay, perfect. Those are other things that could affect those areas. Go ahead. Senia? Oh, okay. Accidental unmuting. Okay, very good.
So sorry. My baby.
No worries. No worries. So, so we want to know, and the beauty of these tools is you can use them in every single session, right? So for example, in our walk-in sessions, we use that in every session. You can use them in a way, you should use the questions how they are, but you can explain to your patients so they don't feel like, okay, well, welcome, we got to do the PHQ-9, check off. You can do it in a way where they feel like, you know, it looks like in terms of what I just asked you, you're experiencing what we consider moderate depression. Have you thought about that? Have you heard what are some things that you can do? Would you like me to share some resources that we have that we can send you in the community? So at that moment, then we're doing a little bit of prevention before we get to a crisis, right? Okay, so that's number 2, screening tools. Number 1, baseline information. Number 3, understanding that suicide and homicide ideation is multifactorial. And what does that mean? Just like substance use disorder treatment, if it is multifactorial, a multifactorial problem, meaning there are multiple factors that are affected, we need multiple solutions, right? So it's awesome that we tried really hard, maybe in my office as I'm seeing my patient, but I need a team, right? So I need to refer the patient to as many services so that they can improve, right? So not an alone job, which is good, right? Isn't that great news? Especially if you are in settings where you have a team. Now, if you're in private practice, then why not talk about to other people in private practice or even clinics where you have good connections where to send your patients, right? So notice all the different areas, right? Personality disorders, substance use, severe medical illnesses, right? So access to weapons, life stressors, psychological and psychodynamic vulnerability, family history, hopelessness. We know hopelessness is a very key factor to predict when someone's not doing good. And in combination with certain questions, if hopelessness is present, that person will attempt, right? Even if they might say nothing, or they might might share very limited information. Notice neurobiology, right? If my brain is not producing enough chemicals for me to go on about the day, it's gonna affect how I feel. Okay, so here, this one is for us to remember. There's a difference between risk factors and warnings, right? So there are things that are happening and increasing the chance that somebody will hit that point. But there are also warning signs. Sometimes our patient is sharing with us, right? They're talking a lot more about why they don't want to wake up. Maybe they don't say, I want to die or I want to kill myself, but they talk about like not being around. If, I'm just such a burden, what a waste of life or breath, whatever. We need to listen, right? And feeling trapped. Sometimes you might hear someone who's sharing how they feel trapped in their relationships, in their job, and it's starting to grow. So those are warning signs for us to be on the lookout. So what that means is we need to pay attention to the factors that put them at risk, but then understanding we cannot change them. There's some that are non-modifiable, like family history, like genetics, like neurobiology, and there's some that are modifiable, right? And what that means is there is something we can do in collaboration with the patient, never making the patient do, but in collaboration. I think it's very interesting. I think I mentioned to you, and we'll talk about that in one of the later numbers. If we have collaboration, sometimes we can have such a great collaboration that we can have a relationship with the patient where we're like, I think it's time, right? I think you're not doing so good this time, and I think at this point I hit a wall. And I think it's about keeping you safe. What do you think? And it's the collaboration is so strong in understanding that we can help by being very open with our patient, that our patient then feels very safe to say, you know what, you're right. Yeah. Even when a patient has to go and they really don't feel like going, like a C4E, like a certificate of evaluation, we can still rebuild that rapport, right? We can work if there were any ruptures, because we have a good understanding that there are things we can do and we do them, right? Notice that there are also modifiable protective factors, right? So very good to talk with our patients. What are the things that keep them going, right? Keep them responsible. And you'd be surprised. There's so many different things, right? So I've had a patient that didn't know with whom to leave their dog. And so, and they felt like nobody would take care of their dog the way that they would. And so that was a huge motivator. Reality testing, right? Positive coping skills. So we might, before they leave and we're doing that treatment, the safety planning, we're coming up with some skills that they can use. We can remind them of some skills that they can use. Enhance their social support, right? That may include, I'm sure many of you have cases where patients say, well, I have nobody out there. What do you think of coming to some of the groups that we have in our clinic? What about attending some things, some good support groups in the community, maybe smart recovery? And so at that point, social support could mean a lot of things. Always collaborating with our patients and asking. And then positive therapeutic relationships. Knowing that we care, right? Be careful. Caring is a little bit different than saying, I'm just really worried. I'm just really concerned. Because then eventually our patients are really good at saying, I don't really want to worry my therapist. I just don't really want to put her there. I remember once hearing about a kiddo that told that to the therapist, I don't want to share things with you because I don't want to make you feel bad, right? So be careful. Caring, concern, right? Question for you. Let's see. Going to the next one. Actually, it's gonna mess it up. So let me see. I'm just trying to read it here. And I cannot read it. You're gonna see the answer that I messed this one up. Let me see if it does it. I'm hoping that it does. Okay, good. Whew. I thought it was gonna put the entire slide. Okay. More people commit, right? More people die by suicide in the winter months. Myth or fact? That's what I get for copy and pasting from one of my colleagues. Okay, myth, fact. Okay, very good, very good. Pretty mixed. Okay. Yeah, we hear it all the time, right? On the news, everywhere. Okay, ready? It's a myth. Actually, the highest rates are during the spring. Any guesses as to why? What do you think? Why the spring? I mean, the fall, you're getting at something warmer, more energy, allergies. Oh my God. Yeah, some of us have really bad allergies. Signs of new life. Yeah. So in the spring, if I'm really depressed, in the winter, we're all isolating, we're all feeling down because it's cold and the sun hasn't come out as much. In the spring, the sun is out. And for those who don't deal, say, for example, with depression, they're feeling good. They're going out and doing things. But maybe me, who is struggling with depression, I'm not going out. I'm actually starting to notice I don't have a partner. Somebody mentioned that because anyways, just I don't have a partner. I cannot do some things. I'm not able. And so then I start noticing all the things that I fail, all the things that I'm ashamed, right? And so it's pretty interesting how in the spring we actually have higher rates of people who actually died by suicide. Very good. Very good guesses. Okay, ready? Is there a copycat effect when people learn about a suicide? So what do you think? Yes or no? Myth or fact? Yes or no? Okay. Going back and forth. Okay, so this one seems pretty mixed. I like when they're mixed. Was it on TikTok? Oh, like if you mean like if the person about the suicide was on TikTok, or it depends. Victoria, you're a good researcher. Yes. Okay. So actually it is. Yeah, it depends, right? So the reality, there could be a copycat effect if there is no talking about it in a therapeutic, in an informative way, right? So I don't know if you know, there's actually in some places a law that really encourages, I think, newspapers and in certain news outlets to provide information about a suicide in a very specific way, where you're providing resources, where you're providing talking about like how suicide is very real. It's not a thing of attention. So they'll tell you the news, but they will explain, seek help. This is something that can be changed, which is really interesting. Because I'll tell you, when I used to work back in El Paso, sometimes we would try to go into the schools to see when there was a suicide, to see we could talk about it with the classes, and sometimes the risk of liability felt to them a little bit much stronger than the benefits of talking about it. And so what happened very often, then you have this copycat effect. Remember, I forget what year, when in the news it was announced that Robin Williams died, there was a bit of an increase in suicides, right? So there's definitely this copycat effect if we don't talk about it, if there's no education. So if it's going to be addressed, you really want to talk about resources. You really want to talk about how it definitely is not a solution. So great. Okay, let's see. Number 4, observe. Not only do you collect data even though they're self-reported tools like Heather told us, but we're also observing, right? Hey, our patient looks different today. Something's not right. If it's psychosis, right? Psychosis is, they're presenting a little bit extra off, right? So I really want to ask questions about both suicide risk and homicide risk, right? So we definitely want to ask, right? So the MSE, the mental status exam would be one example, but there are many other ways, right? So you might not use the MSE, but you can definitely observe, right? Is the patient usually dressed every time, right? The same way. Are they appropriate, right? Are they overdressed, meaning like too much clothing when it's really hot, or vice versa? In their thinking, are they their usual? Did they have the usual mannerisms, the usual talking, or is it a little bit different today? So observations are super, super important in all of our fields, right? It doesn't have to be just therapy and just medical and nurses. It is definitely in other places. So always observe. And then the beauty is, for some of you professions, you actually have to record, right? No problem. You have to usually record what did you observe, right, during the session? What was something that was the same, or there was a major change? Okay, so let's say we collect the data. Let's say our patient is, they're struggling, but it seems similar, but then all of a sudden you're seeing warning signs, you already had the risk factors, and the warning signs are increasing, then we definitely should complete a risk assessment. One thing that I often share with supervisees is that every session, like we always think only when they say, oh, crisis, there's a crisis, we need to address it. It feels like that's the only time we should do risk assessment. We should always do risk assessment. We just do it in a smooth way, right? So our patient comes in, they're talking, we're observing, we might collect a screening tool. All of that is so that we can determine, is our patient a risk or no? Nope, no risk. Their PHQ-9 is about the same. I'm observing their usual self. Okay, now we get onto the therapy session, right? Or the intake, or we're going to do whatever it is else. But the reality is, it's unspoken. Every session that we meet with a therapist, a patient or a client, we're actually assessing if there is any type of risk, okay? The reality is, we often forget. Nothing like we have them fill out the PHQ-9, they left, and you look at the PHQ-9, and number 12, the question says, they say that they're struggling with thoughts of wanting to kill themselves or harming themselves. And it's like, oh man, I forgot, I totally missed that out. So I now need to check in with the patient, because we just don't know if they're a risk for suicide. So if you're going to collect that data, make sure that you check it during the session. Usually at the beginning is a good place. Question, PHQ-9, can you use it as a predictor of somebody having that somebody will harm themselves? And I think I'm curious, what do you think? Can you use it as a predictor? It helps a bit. Yes. How is it tempted, right? So yeah, so in question 9, and yeah, for those of you, if you're not familiar with PHQ-9, question 9 asks if you have thought of killing or harming yourself. Okay, so what's really interesting about that question is 2 questions in one, and not to get a little nerdy, but for those of you who took psychometrics, do you remember we're not allowed to put 2 questions into 1 question? Right, so that actually makes your instrument or tool very poor. You should only ask 1 question. So we'll talk a little bit about specific questionnaires that we can use for assessing whether or not there's a high probability that somebody will harm themselves or harm others, but particularly themselves. So yeah, so I think that it depends. It's okay, because we could collect the data and ask more questions, that would be appropriate. But if they say yes, we cannot assume that then there's high SI, right? We definitely need to ask more questions because that question is just confusing. Which, by the way, I don't know if you remember the PHQ-9, it asks you if you have any problems concentrating while reading the newspaper. I love that one, right? I don't know how many of you actually like pull out and read a newspaper. Okay, so it definitely needs to be updated. So presence of those, okay, talking slowly. In relation, can you say a little bit more, Delia? If you can just join.
That's in the PHQ-9, it always like mentions like talking slowly, and I just always wonder like what if they always talk slow or softly. So yeah.
I agree. That's another good one. Yes, I know. We definitely have some interesting questions and questionnaires. Okay, very good. So let me go to the next one. So when is risk assessment indicated? As I was mentioning, not only during when there's a big change, but at other places, right? So it's okay for us to ask how things are. But again, remember, we're doing evaluations that can tell us some baseline data, right? So, but there might be other places where it is indicated, right? So all of these are a good list to keep in mind. And then risk of harm, let's see, sorry. So here are two tools. There are other tools in the internet. Hopefully this is not too heavy. It is heavy with lots of wording, but let's go through it. So there are tools out there. I put you the two that are the most widely used, but there are many tools. Maybe your organization use something different than this too. But when you're looking at an instrument, and again, let's get a little bit technical, you want to make sure that it has good validity, good reliability. What do we mean by that? Reliability, that it's going to give you the same results. So if you test me and I have high risk, it shows you high risk, and then you give it to me again, and I have high risk, and it does, and then when I have low risk, it has low. So it's reliable, right? And valid is that it's actually measuring risk and not something else. So there's some questionnaires out there that actually tell us they're measuring something and they're not, right? Or they're confusing, and we need a lot of extra data. And so we need a tool, and what was really neat about the Columbia, it's Dr. Posner realized we need a tool that can be easy, and not just us, everybody here who is either a therapist, a peer, not a tool that can be easily asked, but anybody out in the community can use it. If you go online and you look for it, there's even an example of a cop, right? Talking to somebody who's by a bridge and is acting a little bit, the behavior is a little bit abnormal, or just not the typical. I shouldn't say abnormal, but in very simple questions. So we'll talk about that. So notice that I also added in here, for those of you who love all that stuff with psychometrics, right? So it has the Columbia Suicide Severity Ratings scale. It's one of the most widely used. I would say the number one reason is that bottom last item, which is free, right? And then also it has really good inter-rater reliability, right? So there could be three of us sitting here using it with the same patient, and we all give the same scores or very similar. Test, retest, meaning you do it today, you do it next week, you do it the week after that, and you still get the same results. And concurrent and convergent validity means that I can take this test and it gives me the same results as if I use the bottom one, the Beck scale for suicide ideation. This is the one that I highlighted for you. It has very strong predictive validity. It's one of the few tools, if not the tool, that will tell you if you answer, I forget if it's 5 or 6, but one of the 3 lower questions, that person will try to take their life or harm somebody else, but really take their life, because this one's for suicide. So it's very important that it has such a strong validity, right? Notice that they both can be used at different times. It's interesting that the CSSR, the Columbia, can be used also with kiddos, with children, versus the Beck is with adolescents and adults. And it's pretty pricey, actually. So if you have an organization, you have to pay quite a bit to actually get it, right? So, okay. But at the end of the day, there are tools out there. At the end of the day, make sure you know what tool does your organization want to use and what are the steps to follow. So for example, for us, the hospital, we use a Columbia. I mean, it's a free tool, but then of course it has an amazing predictive validity, right? So it has really good questions. Now, with that said, I'm sure some of the therapists that are in here that are at our different UNMH clinics will tell you it can be a little tricky, right? Because it can show that somebody has a moderate risk where you're trying to consider whether or not, what are the steps that you're going to follow, right? Inpatient or not, even though the reason why it hit moderate was because they had an attempt 10 years ago, right? So there's some clinical judgment that you would use there. Okay, let's see what's going to do. Okay, let me show you a video in terms of assessing risk assessment, and let's see what we think. Let me know if you can hear it. So here we go.
So tell me, what brings you
Hear
to
it?
see me today?
I've been feeling kind of crummy, problems with my family, and things at work aren't going so well.
Have you been feeling depressed?
No, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
Right. I'm stopping you there. This is very true sometimes of situations, which is pretty sad, right? I know, I wish he was a little bit more relaxed. He's showing us how the Columbia can be done the right way and the wrong way, right? But we have to be cautious because we still hear people asking that way, right? And it really is more about our uncomfortableness, right? But we feel very uncomfortable asking, and it's like, oh crap, now my patient is saying that they're thinking of, oh, but that's not going to happen, right? That's for me. That's the safeties for me. I'll tell you, one time I have a loss of hearing, and I went to see, I have tinnitus, and I went to see the person that was working with me. And her question, when I was shared that it was getting pretty loud, her question was like, but you're not going to kill yourself, right? And it was just so inappropriately asked, right? And so very important for us to make sure we practice this with everybody at home, especially those of you who are trainees, practice over and over. And really, if you ever catch yourself saying something like, but you're really not going to do that, for a moment, pause and think, okay, I'm feeling uncomfortable. I need to go back. Well, let's talk about it, right? You can still fix it. Okay, so
see how asking the wrong question
Dr.
can shut down
Posner.
the conversation? Watch now how asking the right questions using the prompts on the CSSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So I'll stop it there. You're welcome to watch it. If you go to the link, the first link is a video. The link before is actually Dr. Posner talking about why she developed and the questions that are there. I want to show you the actual questions in the next one. And I mean, if you go to the link, it's actually a video. The one thing to be cautious is the physician says, the psychiatrist says, if question 1 and 2 are yes, and everything else is no, then there's no risk. I would just say if 1 and 2 are yes and everything else is no, still have a good talk with your patient. Like, what is it that can help them so that they don't feel like that, right? So that would be the added caveat. But nevertheless, I love this. So when we ask question 1 and 2, that's going to give us information. And notice this is like from the PHQ-9, but it separates it. So area where we learn about suicide, question 1 would be a measure of death ideation, not suicide, death ideation. That's it. The second one is suicide ideation. Now, notice number 3 can definitely increase it to moderate or high, because you're having thoughts. It could, but then what really kicks it into like full moderate, full severe, would be if you're either rehearsing, have a history, et cetera, because we know if somebody has a history, their risk is higher, especially within the last 3 months. So that's very important. So if somebody's coming out of a hospital and you're seeing them, say, for example, with us, you're seeing them during walk-in, you really want to talk about safety. What are they going to do? Because that is the highest risk for them to die by suicide. Okay, so very important, the Columbia, and I think I saw somebody put something, actually ask my friend if they feel mentally safe. Okay, and there's some other ways, like you can find, SAMHSA put out a campaign called Ask, and it teaches, again, how can we just ask? What does that mean? And as therapists, as the different fields, right, as nurses, we should feel comfortable asking, are you thinking of killing yourself? I've been actually pretty surprised in a good way how sometimes family members have learned to be very safe, especially when there is chronic suicide ideation, thoughts of wanting to die. It's very good to see how mom, wife, husband might say, hey, are you thinking of killing yourself? What's going on? Share it with me. Tell me a little more. Than just saying, are you not feeling well? Or we use a lot of euphemisms, right? And again, remember, that's for us. So it's good. It's really good. So you can start with mentally safe. And if you feel like something is off, maybe even asking, right? We want to keep our friends alive. We want to keep our patients alive. Okay, so here are some specific steps and examples, like, for example, what happens at UNMH. So you want to know what happens at your clinic. In terms of suicide, the biggest thing to remember, it's not as predictable, even though there are risk factors. And then I know that I mentioned risk of homicide, right? So there are a couple of tools out there online, but they're not very, let me just put the whole slide. They're not very widely used. Actually, us here at the hospital don't have one specific one that we use, but we definitely want to consider risk factors, right? There's no heroes in this field. Your safety is the most important one. And so when you feel in a situation where you need help, when you need somebody else coming in, you definitely, it's important to jump in. One thing to mention in terms of risk, and for you to remember, and again, here are the details for those of you who love the details, is New Mexico uses a TerraSoft rule, which it's controversial, especially for people in our field, psychology, counseling, social work, therapists, because that's a point where we have to disclose, so we break confidentiality. And it's based on a case that happened in the 70s where a patient had told the therapist that they were going to kill someone, even though they didn't name who it was. It was easy to know who it was. It's a girlfriend. The patient actually went out and killed the woman. So the law says you must, in our state, we talk to your team, right? Consult. We must really talk about what's happening. Do we need to report? How do we report, etc. Here are some extra edits to that law, and you want to know whether or not how do you handle that, and whether or not your state has that, because I know we have some people from Texas. So it went on it was edited later on because it was a case of a therapist who failed to review the history of violence. So be careful. And then later on, there was another case with the family member warned the therapist, and the therapist didn't do anything. And it was expanded to even if a family member tells you, and they don't have to be an expert in trying to let you know, it's that. I mean, like they just share with you that the patient is at risk of harming somebody else. So very important to remember that. Okay, so the tear-off rule. Work with your teams. I put you 2 slides. This is one from SAMHSA, and here is another one in terms of, nothing like adding the links in a weird way. Another way to remember how do you assess if you have 5 risk factors in your patient and the warning signs are creeping in, then there are 5 things that you can do. Okay. At the end of the day, remember that we assess our patients so we can keep them alive, but then we also assess them for us, right? So why? Because we will have cases. Look, 3 out of 10 trainees have had a patient die by suicide. That's a pretty high rate, right? And so I know we're at the very end. So the last thing that I'll mention is a collaboration, right? So we really have it's very important to collaborate with our teams to be able to know, and I mentioned this a couple of times. I give you an example, like, for example, we have a crisis chat in which we have different people looking at the crises and helping that therapist who's addressing it, because very often when we are addressing a crisis, our mind is not even there, right? We don't, we can't think of the details sometimes. So it helps having different sets of eyes. And for example, in this example I give you, we even come in person if needed. But if not, that one therapist is managing the crisis. If they're doing well and there's no extra help needed in the room, we're helping in the background. So definitely consulting, collaborating with your team. And I apologize. The last thing would be ensuring that you have a crisis plan. So I did have one. And remember, we have a multi-systemic, the crisis or safety plan is only one of many steps, right? So your plan should be clear. It should be in collaboration with your patient. You want a safety plan or crisis plan that's talking about, hey, who are you going to call if you don't feel well? What does crisis look like for you, right? If you're not doing well, how do you know that you're not doing well? So let's put it in there. And then skills. You really want to talk with your patient about what are some things that you've learned here? Say, for example, here at ASAP, what are some that you're really good at using? What are some that maybe we can try out today so you can take with you? And sometimes we plan the whole next hour, the whole next hours, and patient agrees to come back in. The one thing we do not use are no suicide contracts, right? They do not work. They're just for us therapists to feel safe that we think that our patient is not going to die by suicide if they sign a form that says that they were not going to attempt against their life. So suicide plans or contracts, don't work. What works is a safety crisis plan where we're writing all those elements, right? What's keeping you alive? What are some things that you still feel responsible? What are things that you feel hopeful about or could feel hopeful about? And then, of course, that's social support, right? And remember I mentioned sometimes social support can be in the form of what you have at your clinic, at least for that day. What's really interesting about suicide, it's momentary, what somebody is going through that moment of thinking, this is the solution. And so being able to get out of the moment, having people around you, it's going to help so that individual or that person won't actually attempt against their life, right? I'll stop there. I know we're at the 4 o'clock mark. The